Thank you. Okay, so thank you everyone. My name is Tom Grimwood and I work at the University of Cumbria, where I am based in the Centre for Research in Health and Society, and I co-lead a commissioned research unit called Health and Society Knowledge Exchange. So I was kind of briefed to talk about methods in social care research. I need to emphasize that I am not on any of these panels. I do not have the overview that people like Helen and Sue has. I'm going to talk about some potential considerations, I guess, in social care research. And if I start saying anything and I see Helen biting her fist in rage that I'm saying completely the wrong thing, I'll move on very quickly. I think the sort of slight issue with it is it's not as if there's particular set research methods in social care. And I know a number of you are researchers and you'll be well aware of this. So I apologize in advance if I'm going to say anything that's really obvious. I think a lot of the things have already been raised, if not covered, by Martin and Sue. What I'm going to do is talk a little bit about the differences between some of your more conventional NIHR methods and some of the on-the-ground differences when you're doing research in social care. And then I'm going to talk a little bit about some of the approaches that we've taken within Health and Society and Knowledge Exchange, which is broadly along what Sue already mentioned, the realist approaches. It's broadly along those lines, but it's less to convert anyone to a method and more of hopefully a bit of a toolkit for thinking about how their methods might move forward in developing their ideas. So the first thing that I was really pleased that Martin raised was just about the complexity of social care, how overlapping it is, how massive it is, how dispersed it is compared to a lot of health provision. You got to see social care on that kind of continuum of, you know, on the one hand, highly regulated, highly organized statutory provision, and on the other end, your voluntary sector, your very small voluntary sector groups. Okay. In terms of social care, research is not is typically not an essential part of anybody's role. Martin already mentioned this. Social workers don't get promoted for publishing articles, generally speaking. They have to move to universities to do that. You won't find many privately run care homes with R&D departments, many of them anyway. So compared to more typical health providers, research is not central and often plays quite specific parts, but often the first role of the researcher who wants to do work on social care is essentially persuade organizations that there's a reason for them to take part in this, which I'll come to in a minute. There's a long history of why research hasn't been central in social care, which we won't get into. Well, also, I just mentioned about the complexity of organisations. We did a piece of work for the NIHR in the Northwest on the research readiness of social care organisations. We did a big scoping review of all the organisations. Just to give you a bit of an idea, if we ignore the statutory side, which is massive in itself with all the unitary authorities and metropolitan boroughs and county councils and all that, you think about the number of charities involved in social care across the UK, you can see, you know, we have a hefty amount in terms of what they who they cater for. Again, we're talking about thousands and thousands of hugely varying in sizes organisations that are potential to work with. In the Northwest, for example, there's 992 community outreach groups dealing with dementia. 992 just in the Northwest, and that's 6% of the entire country's number of community outreach groups. So it's big. right? It's big. And in some senses, that's a benefit because of finding research partners, finding people to work with. But also because social care interlinks, often what social workers are doing is connecting up different groups. A service user, as Martin said, will often be working with several different organisations. So that adds this level of complexity to delivery. I also was really glad that Sue said that the research about how people feel about something isn't as important at this stage. How it leads on to something, what does it actually change? I'm going to talk a little bit about how I conceive of, how I would approach that. But also Sue said something very important about there must be clear answers. And I agree there have to be clear answers, but we also have to remember that clear answers aren't simple answers. And in my experience, nothing is simple in social care at all. Because of that, the kind of evidence that we have to present doesn't map or isn't as well established or embedded as it might be in the health professions, for better or worse. So there's not the same hierarchies of evidence. There's not the randomized control trial at the top and all the softer stuff for the non-consultant and non-clinicians to do at the bottom. It's really about what evidence is appropriate, and within that, I suggest there's a real need in social care to think outside of some of those conventional research routes. So, sometimes health research can get very bogged down on quants and quals. I don't think that's really necessary anymore. I don't think that's always appropriate to social care. We don't need to be dividing these up. We just need to be thinking about what is the most appropriate data collection to inform the evidence we're trying to show. There was something else I was going to. Oh yeah, and because of that, that was why the one thing I didn't really agree with on Martin's call, and he's not here, and he's far more senior than me, but I'm still going to say it. Is when he talks about adding on social care to healthcare research or plugging it on at the end. I'm really wary of that. I'm really wary of that because unless an intervention has been designed with social care at the table, it's likely just going to succumb to that kind of traditional health way of doing things. Likewise, the value of the research is going to be different. This has already been talked about. How the research is going to be disseminated, but also how the research would benefit a social care organisation. So often for third sector groups, it will be about continuing their funding. It might be about expanding their programme of opportunities, using the evidence that research is generating to actually sustain their mission in a way, which is sometimes a little bit different from other kinds of research. What in general I'd say, and I've been talking too long already, is the lack of a historical research culture in social care, sort of takes up one side of it. On the other side, there's a lack of robust evidence. There's some long cultural histories of lack of evidence-based care being used in social care with pretty bad results. It opens up this really nice space of opportunities that this kind of funding is offering us. Okay, but we have to keep a mind on complexity and making sure we're representing things properly. We have to have that whole systems view, which I think Sue was talking about, the whole systems approach, but ensure that it's not just a top-down view. So in terms of how we do that, I'll start with one of my diagrams. This I've robbed from the Health Foundation, I think, but it works very well for social care as well and for interventions. It sometimes helps to work with a kind of matrix approach. So the idea of this table is that we have, if we're trying to implement change somewhere, there's strategic elements, there's cultural elements, there's technical elements, there's structural elements. You have to have all of them in play, and you have to have your eyes on all of these as a researcher in order for effectiveness to be happen. And what this table is trying to do is show if you don't have, if you have culture and the technology and the structure, but you don't have any strategy behind it. You don't have any long-term effects to the changes that are made. So I think using this matrix and approaching the way that your particular area of social care that someone might be interested in is quite useful to try and map out all the players and the stakeholders involved. I talk a lot about culture because there is a lot of ingrained culture in social care. There's ingrained culture in any kind of organisations, but social care has its own distinct flavour. And again, thinking about where the focus of research might be, I like to use this table from Shine. I think it's quite old now. I'm not an organisations person, but it's from Shine about culture in an organisation, where often the very observable things that we can collect data on are the straightforward things to change, but the more embedded things that often ensure that there's long-term change and there's long-term impact, they're much harder to see and much harder to unpack. So in terms of data collection, surveys and whatnot might start to pick up things around the observable elements, the sort of the top level of how people act and work in a particular context, but deeper dives might be necessary for looking at some of the assumptions that carry that work. And that is also where the politics comes in, which I won't talk about obviously because Helen will shout at me if I do, but that is where the politics of an organisation might come in. Trying to bring all this together, what I really feel in social care research, if I was going to separate it from other forms of research, is you have to avoid the black box approach. You have to avoid counting the inputs. Something happens in the middle, and then you count the outputs, and you say that the input worked or didn't. Okay, that black box approach, which is used a lot, particularly in health evaluation, it's just not very helpful given the complexities of social care. Now, I've talked about realist methods. Like I said, I'm not going to give a full introduction to it, but the reason that I like it is because it's about first and foremost mapping the full extent of variables that go on in a particular context. And the way that that's done is by mapping out, understanding 3 dimensions of a particular intervention, a particular issue, a particular problem: the context, the mechanisms, and the outcomes. Some of you will be very familiar with this, so apologies. From that, developing a hypothesis. From that, organising appropriate data collection. From that, analysing. And from that enables a sort of constant cycle of research rather than just a one-off piece of work. So that's important for sustainability. What I mean by context, mechanisms, and outcomes are contexts are basically themes that are outside the particular intervention or project you're looking at, but may have an influence on them. So if we were thinking about putting a project together, the context, we might be looking at things like PHE fingertips from Public Health England that give a good overview of some of the social care population needs. Historic aspects of social care, which are very important at localized levels. Mapping those, mapping populations, mapping, so you see it can be quants or quals, whatever. Mechanisms are the actual things that are trying to initiate the change, and the outcomes are what is meant to happen at the end. Okay. And the reason you're mapping them is to develop a hypothesis that if you do that mechanism in that context, that outcome will happen. So it means that you're not reducing anything. You're able to try and capture everything that's going on, all the different organizations in play, to try and decide on the specific thing that you need to test. And from this, you get what realists call a program theory, an if-then hypothesis. You collect data according to the best way to evidence that hypothesis. You revise it, you keep going. And that's the scary bit. That's what it's meant to look like in detail. Just a word, and I guess the point I was trying to make was that I've used the word themes here, but that can be qualitative themes, it can be quantitative themes, it can be visual, it can be documentary. It's really just the framework to try and hang the complexity of social care interventions on. And in terms of outcomes, it's often about breaking down the very high level outcomes, something like improved in quality of care received, which are important for social care organisations to justify funding or gain more funding. Using those outcomes as key to the research, but then breaking down those outcomes into a number of different ways it could be measured, because a lot of social care, the emphasis on well-being, the emphasis on quality of life, they don't lend themselves to singular metrics in the way that, say, acute care outcomes do. Okay, I've probably gone way over my time, so I'm going to stop there just in case there's any questions